the hybrid OR not only allows us to do an open procedure or a minimally invasive procedure, but it also allows us to do diagnostics, so we can determine what the problem is and then treat it all in one sitting. Whereas before, if we wanted to do that, we would have to move the patient out of the operating theater and down to the CAT scanner or over to the diagnostic lab to figure out what the problem was. So being able to have that allows me to apply all the training that I did, almost 10 years of training, to be able to serve Nova Scotians with all the newest technologies and all the options that we have before us we can provide to Nova Scotians. The hybrid OR is becoming the standard of care, and although this is going to be the first one in Atlantic Canada, there are lots of hybrid ORs in other parts of the country, and if you have training like mine, you want to be going to a center that has a hybrid OR, otherwise you can't use your skill set. So I want to talk about innovations in cardiovascular health right here in Nova Scotia and actually in the Atlantic provinces. So the hybrid OR, let's start there. So it's basically the melding of two rooms, the operating theater as well as an interventional suite. So the operating theater allows us, many of you may have been in one before, it allows us to have equipment to put you off to sleep, and it has surgical equipment. It's a big cold room, lots of space to do open incisions. The interventional suite is a lot smaller and it has very high-level X-ray equipment to allow us to do minimally invasive procedures, also called endovascular procedures. And they're called that because we do them from the inside of the artery, so endovascular. It gives us the capacity to do either open surgery, endovascular procedures, or any combination. And sometimes things are unplanned, and you may be doing an endovascular procedure and all of a sudden something has gone awry and you need to convert to an open procedure. So the hybrid OR allows us to do any combination, planned or unplanned. So like what? What kind of surgeries are we talking about here? Well, aneurysms, for example, of the major artery of the blood vessel called the aorta. So that happens at any level of the aorta. And we can do an aortic aneurysm repair in an incision this big, where traditionally in open surgery we're looking at a big incision here or a big incision through the breastbone. So that's been a huge change for patients and their recovery and their care. Emergencies, so sometimes we lose control of a bleeding vessel and we can basically access and control a bleeding vessel within minutes, versus the open technique would take us tens of minutes to get in. So that's quite a progress in the technology. Proximity surgery. So one example of this would be cancer surgery. If a large tumor, for example, is adjacent directly onto a blood vessel, and it's very high risk for the surgeon to do that procedure, we can go in and protect it either on standby, or we can go in and put a covered stent in there so the resecting surgeon can actually take the wall of the artery away because there's something already in there protecting the artery. So that's a big advance in cancer surgery. And accessibility. There are parts of the body that are very difficult to access surgically. So those are things behind the bone. And my favorite example is the clavicle. There's a little part of the blood vessel behind the clavicle. It's about that long. And you would have to do a full incision just to access that 2 centimeters of artery. But with a hybrid OR, we can make an incision that small to easily repair that blood vessel. So I thought it would be fun to give you guys some examples, and I promised everyone there's no gruesome photos. They're all going to be black and white photos of imaging. So we have a penetrating injury to the abdomen, to the belly, and the patient presents to us and he's very unwell. So low blood pressure, the blood counts or the hemoglobin is very low, and he's so unwell we can't even put him in the CAT scanner. We take him right to the operating room to figure out what's going on. So while in the operating room, he actually stabilizes. And we know he's got an injury deep in his pelvis, but we don't know what it is. And that is no man's land down there, so it's quite dangerous to start operating in that area, especially when you don't know what the problem is. So we actually make the bit unorthodox decision to take him out of the operating room, down to the CAT scanner, put him through the CAT scanner, find out where the problem is, and then take him back up into the interventional suite. So that's a huge delay in care for him and very risky. Transporting the patient is one of the riskiest times for them. So what do we see? Well, I was teasing earlier that this looks like a nice piece of art that you might hang on your wall, but it's actually what we call an angiogram. So this is a tube that's gone up the vessel and it's shooting dye down the arteries of the leg. So your belly button would be right about here, and these are your blood vessels of your leg. So one coming down to the right and one coming down to the left, okay? So you can see dye, or that black stuff, is filled in the blood vessel. But we have this thing here that's not in a blood vessel. And then there's also that thing that's not in a blood vessel. And then there's this over here. That is actually blood going from the artery into the vein. So this person's injury has injured both the artery and the vein. And it's bleeding into his abdomen, okay? So to fix this surgically, I would have to make that incision. He actually already had that incision. And I would be like looking down as far as I could to try to repair that blood vessel. And I'd actually have to divide the artery and fix the hole in the vein, which would put him at a huge risk of limb loss. Okay, this is a young person, and a risk of death. So instead, we take him to the interventional suite. And you can see here, we're looking down the left leg, and here's our bleeding outside the vessel. And now you can see there's this wire that's coming through the vessel. And you can see there's a little dot there and a little dot there. That is a stent. So a stent is a wire frame. And this is a covered stent, so it has material surrounding the wire frame, so it's impermeable. It's like a tube. So some of you may have stents, so your heart, or you may have heard of someone who's had stents. It's very similar. So what we do is we're actually going to open the stent up. And here we have the stent that's open, but you can kind of see the edge kind of coming down right there. I hope you guys can see that. But it's still bleeding outside the vessel. So we go in, right there. You can see that the blood is coming around that stent and still bleeding outside the vessel. So we take a balloon, and we mold the stent to the artery. And now you can see these are the edges of the stent right here. You guys can see that, I hope. It projects. And now, ta-da, it's all fixed. So there's nothing bleeding anymore. That procedure took us about 20, 30 minutes to do from start to finish. And it saved the patient a very dangerous procedure. Now, if we had had the hybrid OR, he could have gone straight to that hybrid OR, avoided the incision in the abdomen, and would have been home probably the next day. But instead, he stayed about a week or two in the hospital. Fall on the ice. I may have fallen once or twice. Not necessarily on ice, but there you go. So it happens to lots of people. So we have a gentleman who has a fall on the ice, and he has severe abdominal pain. It takes him to the emergency room. So he comes to us, and he has low blood pressure. His blood counts are low again. He's not stable, and he's essentially, we can tell he's bleeding into his belly. So this is a CAT scan here. This one looks a little different to identify, but it's a section across the pelvis. Okay, these are your pelvic muscles here, and this is your tailbone. And this stuff, that is not supposed to be there. That is all blood in the pelvis and in the abdominal wall. Okay, so this guy is in a bit of trouble. So here we have another dye test, or an angiogram, and we have our catheters up here, and it's shooting dye down into the pelvic arteries. Okay, and we can see it all looks like the dye is going through the arteries pretty good, except for what's that guy right over here? That's not supposed to be there. And in fact, here we are at the next slice of the image. There's a blood vessel that's pretty tiny. I mean, like we're looking at that's like a millimeter, maybe, that blood vessel that's causing all that problem. And it's just freely bleeding out into the abdomen. So we already know that the pelvis is not a place where I want to operate. So this guy, again, would require, if we were going to do an open surgery, a big incision through the abdomen. And that vessel is so small, it would be like looking for a needle in a haystack. Okay? So let's take him to the hybrid OR. Yay. So here we have our tube, or our cannula, coming down, and a little wire. And this little twirly thingamabob, it's called a coil. So basically, we shoot that into the artery, and it coils all up, and it causes the artery to clot off, okay? So that thing is about that long, and it, again, takes not very long. It'd take about an hour to probably find that little blood vessel and get the coil down there. And there it is. So here's our coil, no more bleeding. So that tiny little coil just saved that guy's life and saved him from a huge, huge operation. So why is the hybrid OR important? Well, as technology advances, we need to keep up with it. And technology is allowing us to provide maximally minimal invasiveness, as I like to say. So we can take an incision this big and turn it into a centimeter long incision. And that really benefits the patients because patients can go home the next day, there's less complications, they're feeling better, and we have all the options in front of us that we can provide them. And with the technology, the standard of care is changing, and so without the hybrid OR, we can't keep up with the standard of care until now. So that's really exciting. And there's so many untapped possibilities. So, usually we say that innovation creates technology, but in this scenario, technology really creates innovation for us. So who knows what we'll be doing in 5 years or 10 years, and who knows what kind of procedures we'll be offering our patients that we've never even thought of. So it's really an exciting time for the Atlantic provinces to have their first hybrid OR. All right, so let's move on to change gears a little bit and talk about some of the innovative research that we're doing at the QEII Health Science Center. So we're going to talk about social determinants of health. And so what on earth is that? Well, social determinants of health are a range of personal, social, environmental, and economic factors that may influence health. We started shifting our gears to look at other risk factors of health, like social determinants of health. So examples of that are your income. How does your income influence your outcome in cardiovascular disease? One interesting thing is smoking. Smoking used to be a disease of affluence, that people who could afford cigarettes were the cigarette smokers, and now the reverse is true. So the lower your income, the more likely you are to smoke. Education, how does education affect it? Gender, so what's the difference if you're a male or a female? Ethnicity, and your physical environment or geography from the hospital. So why is this important? Well, social determinants of health can contribute to inequities in health outcomes, in cardiovascular health outcomes. And because we don't often think about them, we're not addressing them. And these can mean differences in death and also morbidity or complications surrounding cardiovascular disease. There is a group in Nova Scotia who has the highest rate of high blood pressure in the world. They're 6 times more likely to die from heart disease. They are 4.5 times more likely to die from a stroke. They have twice the rate of diabetes. And they are 1.5 times more likely to die of peripheral vascular disease. So does anyone agree with me that that's a health crisis? Okay. Does anybody know what group this could be? Good guess. It's the African descendant group. But the First Nations, are often a neck and neck, which is not a great competition to be in. But definitely First Nations are up there. So why is that? Well, Nova Scotia has a long history of oppression of African descendants. There's inadequate research on the topic. There's a lack of cultural representation in the medical field. There's cultural bias, and there's systemic discrimination. And there's lots of studies out there, though, that show that doctors have unconscious bias. And in one study where patients were presenting with heart attack, they showed that doctors were less likely to diagnose them appropriately if you're African descendant, and also were more likely to prescribe alternate therapies this is an American study, that were cheaper. So there definitely is an unconscious, discrimination or a bias that's going on how we treat our patients. So in my opinion, it's a health crisis. And there's lots of systemic change that needs to happen, but we can't wait for that. So we have been working with the Health Association of African Canadians, and this is a collaboration with the Department of Surgery. And our goal is to determine where the inequities in access to healthcare and outcomes are, to start with. You need to know where the problem is before you can attack it. And one of my goals, and cardiovascular, there's actually a lot of research out there in the US data anyway that shows that African descendants have very poor cardiovascular outcomes. And there's a Canadian and Nova Scotia level data as well. So we kind of already know it's a problem in cardiovascular disease. So I really want to change how this group accesses healthcare. So I just want to give a little comment on some of the other research we're doing. We're basically doing that project with the Indigenous and African descendants, and that is Dr. Mike Dunbar in orthopedics and myself are leading the charge. And we're going to be doing that with the entire Department of Surgery. So we're going to be looking at colorectal cancer, prostate cancer, peds, ears, nose, and throats, plastic surgery, any access to orthopedic surgery, anything you can think of. We're going to look to see if there's just disparity in those groups. And this is really exciting because it's the first time we've ever had a database so big. It's a Canadian data set with ethnic identifiers. So this study has never been done in Canada before. So it's very, very exciting. We're looking at socioeconomic status, so income and geography. We're looking at access and outcomes in heart surgery and stenting versus open heart surgery. And we know based on the data which patients benefit from which one, but we don't know if that changes based on where you live in Nova Scotia. So if you get stenting done in your heart and you actually don't have a cardiologist because you live in Meat Cove, how does that affect your outcome? And maybe you're better off having open heart surgery, or maybe the reverse is true. So that will be a very exciting research. We're one of my colleagues is looking at decision making, so patient-specific risk profiles. So we just quote you what we know from the literature, but what if we could tell you, you, Mr. Smith, have a 2% risk of this and a 4% risk of that. That is completely tailored to your own set of social determinants of health and classic traditional risk factors. And we're also looking at faster and safer discharge from the hospital after heart surgery. So all really exciting things happening at the Division of Cardiovascular Surgery.